Welcome back from lunch. We got, I think, a pretty exciting session here with some very interesting, timely, and exciting topics. So to start us off, this is the Tearing, much more than just a watery eye session. And to start us off, we're going to have Dr. Rachel Sobel talk to us about when to suspect systemic disease in patients with nasolacrimal duct obstruction.
Thank you very much for the opportunity to speak. Special thanks to Jeremiah and Rich for putting on a wonderful program and including me. I have no financial disclosures. So today, I'm going to talk to you a little bit about the history of NLDO, some current concepts of the understanding of NLDO. I'm going to review some cases of bilateral NLDO that led to a retrospective case review, and hopefully will help you have a new way of looking at bilateral nasolacrimal duct obstruction. So a little throwback in time and history. Does anybody know who this is? He painted this. He's a Danish-French impressionist painter. And close, Pissarro, Camille Pissarro. And he's famous not only for his paintings, but to us for having dacryocystitis, and you can see that here. He was diagnosed with an NLDO in 1889, and they told him to put boric acid in his eye if anything should get in it. And he suffered with this. At the time, he could either have his lacrimal sac removed or repeat probings, and he decided to be treated more conservatively with silver nitrate. And he wrote, "I'm very troubled at this moment. I shall try to work with one eye." Degas does it and gets good results. He had some form of chorioretinitis. And I think perhaps his watery eye may have contributed to the beautiful impressionistic views of these French boulevards. But I bring him up not only because of his dacryocystitis, but because of the timeliness of it. He unfortunately died in 1903, and then in 1904, the Italian surgeon Todi published his work on external DCR. Now, since then, there have been many improvements in external and endoscopic DCR, and our understanding of what causes NLDO has also evolved since then. One of the landmark papers was from 1986 from Lindbergh and McCormick. They looked at 14 cases of unilateral NLDO that were undergoing DCR, and they found a way to biopsy the nasolacrimal duct on block. And what they found was that there was edema in the tissue, it was infiltrated with immune cells, and there was fibrosis. And it was not because the osseous portion was narrow, which was the current thinking at the time, but because of the mucosal inflammation. Further, after this paper came these three very vast and expansive treatises on secondary causes of NLDO. And so if you didn't have one of these secondary causes, then you had PANDO or primary acquired, which is what Lindbergh had described. And in the Bartley papers, he mapped them out to these different categories of causes of nasolacrimal duct obstruction. And so I would like to add upon this understanding of NLDO, and I really want you to consider a bilateral presentation differently than a unilateral one. I think this is a distinct entity. I think it's not the equivalent of two concurrent cases of primary acquired NLDO. And I think it's important to think about an underlying cause when these patients present to you, and there's more information about that to come. So now I'm going to talk about a few of the cases that helped come to this conclusion. So this was a 66-year-old woman who had some intermittent swelling of her medial canthus. She did have a history of known CLL. And here she is with her dacryocystitis. She underwent bilateral external DCR for her bilateral chronic dacryocystitis, and the pathology specimen showed a lymphocytic infiltrate that was consistent with her known CLL. So this was her diagnosis, bilateral NLDO with dacryocystitis due to CLL. Now, CLL and NLDO, what's the relationship there? It is an unusual cause of NLDO. In one study, 3% of DCR biopsy were positive for leukemia or lymphoma. There are at least 18 cases reported of this connection in the literature, and the majority of these patients already have known CLL. And why does it affect the nasolacrimal duct? Well, CLL goes everywhere that blood goes, and will have the opportunity to cause a mass effect anywhere lymphoid tissue normally exists. So the nasolacrimal duct will fit in that category. Also, areas of chronic inflammation are usually a focus for this low-grade lymphoproliferative disease. So that makes the nasolacrimal duct a perfect place for it. Now, a quick diversion about biopsy. Do you biopsy or not? There's been some papers that say you should biopsy routinely. These were early on in 86 and 97. And then another paper really recommended that only if it looks abnormal. This paper looked at 304 lacrimal sacs biopsies, and 10 of them were positive for some pathology. And of those 10, all of them looked grossly abnormal intraoperatively. So if it looks abnormal, you should definitely biopsy it. So we'll go to the next case of a 52-year-old woman with bilateral tearing that worsened over the past year. This was functionally disabling for her, and she had a history of thyroidectomy and high-dose radioactive iodine-131. Her initial exam, she had punctal stenosis and had a probe and stent. She returned 9 months later with functional NLDO and had a bilateral external DCR, and her tearing was thought to be due to the connection between I-131 and I-131 after her thyroid cancer. And as a side note, typically, this is a known connection with nasolacrimal duct obstruction. In my tearing exam, I always look at the neck to see if there's a scar, and if there is, I always ask whether they've had thyroid cancer or radioactive iodine. So what's the story behind I-131? This was first noted in 2002. The average onset is about 7 months. After radiotherapy, it can affect any portion of the lacrimal system, and it happens to occur in about 5% of patients. This number may underestimate it. And we think that there's a rising incidence, one, because people are becoming more aware of the fact that this can cause an NLDO, and also because of the increasing rise in thyroid cancer. So from a physiologic level, how does this work? I-131 is a radioactive isotope. It concentrates in active thyroid tissue via the activity of this sodium iodide symporter. And that symporter has been identified in the lacrimal sac and nasolacrimal duct. And so when it concentrates in there after treatment, it's thought to cause local tissue damage and fibrosis and obstruction. And interestingly, the same thing happens in salivary glands around the mouth. These patients end up having dry mouth and pain in their mouth. And remember that these doses are much, much higher in the papillary thyroid cancer treatment than in Graves' disease. So it really just happens in those high doses. Here's one last case I'm going to share with you of a 68-year-old woman. She presented with tearing, dacryocystitis. She had actually had a bilateral DCR outside. Biopsies were consistent with sarcoid, and she subsequently developed pulmonary and cardiac involvement. When she presented, she had bilateral NLDO again and had an external DCR on both sides. The biopsies were consistent with sarcoid. And 6 years later, she returned and had another tear duct blockage. So 3 on the left, 2 on the right, had another revision. Sarcoid can affect all different parts of the body, as we all know. In the periocular region, it is most common in the lacrimal gland, but can affect the lacrimal sac. And it occurs in about 2% of patients who undergo DCR. And interestingly, in this very large study of the 12 patients with sarcoid, all of them had required a bilateral DCR. And in each case, there was a gross abnormality of the sac and the mucosa. So these 3 cases are kind of representative of some of the cases that I saw in fellowship with Dr. Allen and Dr. Carter. And, we were thinking about this, is there something about bilateral disease that's associated with systemic disease or medication side effects? Kind of like in bilateral uveitis where, there's this suspicion that something else is going on here. Maybe we need to think about that harder and try to find that. These patients can be young, and they seem to require more revisions. So this paper came out of this work here that I'm going to describe. It was a retrospective case series from 1986 to 2012 of all consecutive or simultaneous bilateral DCRs. We had 91 patients. Our control group were patients who had just undergone unilateral DCR, and the age ranged quite a bit. Most of the patients were women, and it was a similar gender breakdown for the unilateral cases. And what we found was pretty striking, that twice as many patients undergoing bilateral DCR had an underlying secondary cause compared with patients undergoing unilateral DCR. These were some of the causes. Some of them were these systemic ailments, some of them were medications, some of them were congenital anomalies. So it ranged from quite a few different entities. And then when we looked at the subcategory of age, we noted that the younger the patient, the more likely the chance that the bilateral disease would be correlated with a secondary cause. And this association was strongest in the less than 50 group, but it actually persisted through age 70. So we concluded that ophthalmologists should have a high index of suspicion for systemic disease or some secondary cause underlying bilateral NLDO, especially in patients less than 50. Then we looked at the incidence of revision and bilateral NLDO. Well, similarly, some striking findings, which was that the patients in the bilateral DCR group underwent revisions at more than twice the rate at patients in the unilateral DCR group. And so what we think is that this may be intrinsic to the underlying anatomic or inflammatory problem, that they're more prone to this. And so I would consider in these patients that you're consenting for DCR that there's a higher rate of failure with bilateral disease. Limitations of the study are that many of these patients were not biopsied, and of the biopsied group, the yield was quite low. And so these secondary conditions are associations, they're not causations by retrospective case review. However, we think that it may actually be an underestimate of the association, as many of these patients, their follow-up was limited and they may have sought care elsewhere. And so I want to ask you, could bilateral NLDO be a form for us presentation of a medical condition? Sometimes we'll see these patients after they've been diagnosed with the condition. Sometimes we'll see them before. And it would be, I think, prudent to just at least entertain that thought when you see them. So take-home points today. Bilateral disease should alert you to a possible systemic etiology, especially for younger patients. I would counsel patients with bilateral disease regarding higher chance of failure. Take a good history, look at the neck, see what kind of medications they've been on, and then consider a serologic workup if you think it's indicated, and also consider a biopsy of the sac if it looks abnormal. Thank you very much.
Thank you, Dr. Sobel.